now I think we are ready to open the session. Today we will talk about scientific evidence for the pessaries in prevention of preterm birth. And we are really appreciating your presence here. Thank you very much for accepting the invitation. I now want to leave the stage to you and for you to give the talk on the use of the cerclage pessaries in cervical incompetence. Thank you.
Okay, first of all, I thank you very much for the invitation. And last time when I was in Turkey, in Istanbul, it was in 2019. And I mainly talked on pregnancy as a window for future health. I met Nina Modi and she became a very good friend because we went together to the Turkish bazaar. And then we now meet on a regular basis. I go to London next week and celebrate her birthday. So I have wonderful memories. I also have a cousin who is married to a Turkish men and living in Istanbul, and they have wonderful children. So I've also been in Ankara. I loved the scenery as well and the good Turkish food. So this is our research center on the campus of a private university where we send pessaries from. And this is the house where I live in the bottom and where we have our teaching center here. So I'm right away in this house now in Berlin. And the profit of our team goes to the Clara Angela Foundation, who organizes creative projects for pregnant women and children. Now we have a project with the Berlin Philharmonics for music programs to increase stress resilience in a pregnant woman. I'm sorry, this does not work. Yeah, no. Well, I have therefore to disclose interests because I own this company, which I founded 25 years ago because no one believed that this pessary would work. You see here, this is me, this little girl, and these are my parents who were a pediatrician and a gynecologist as well. And my father, only for his own patients in our house, he made some kind of pessaries. He died early. And when I went to the Netherlands and had to run and to guide a very large perinatal center, I got so many desperate cases that in some where no therapy would help, I tried it in a desperate situation. And then I did a pilot study until my international friends then stimulated larger studies here. It was decided in Spain in 2016 by Professor Nicolaides to run the first study in Spain. So what I did, I asked the handicapped people of our hospital here in the Netherlands to produce by hand, like Christmas bakery, these kind of pessaries. And of course, in gynecology, pessaries have been known for thousands of years. In Egypt, it started to treat prolapse, genital prolapse by different materials, clay or leather or glass, until we now reach the century of silicon, biocompatible silicon. And we have modified this cerclage pessary during the last 25 years, 2 times, where we changed the material, but also changed the compression forces with different thickness of the walls according to the indication. So when you, in these 25 years where I run this company only as a hobby, more or less, because I continued to be a full-time obstetrician, I was confronted with a European legal situation which became very strict, much stricter than for doctors. in kind of audits and supervision of the quality of work, of guidelines you have during your work, and technical documentation of the products you distribute. And every year you have to fulfill these criteria, you get certificates, and you have to read all these terrible guidelines. It's a lot of bureaucracy, and I'm not always fond of these, but it has also taught me a lot. So what it has taught me is that although we do really have to supervise every pencil we have on our desk during work by producing these products, the cleanness, the procedures, and the teaching, the clinical teaching is poor, because doctors don't read the instructions, which in fact have legal character, and if you can prove that they don't follow the instructions for use, IFU, you can claim them. But nevertheless, most gynecologists think they know everything, and therefore, the few case reports reporting on some problems are always exclusively a fault of poor clinical practice, not considering the instructions for use, which we have to imply to each product. And that is very clear. If you think of laser treatment, nobody would just distribute laser instruments all over the world and say, just start to any nurse, any midwife, any doctor, because the risks of this therapy are high. The risk of cerclage pessary when it is performed in the wrong way are much lower, but the benefit is also lower when there is no good clinical practice. So cerclage pessaries are class 2B products, which means they can stay in the body for more than 30 days. And that also means that the European laws for product are much more strict. And there is a learning curve, and it has been published by Franca in 2021, that the success of treatment is better when you have experience of at least 30 pregnancies. But of course, most randomized studies was performed by distributing the pessaries without teaching, without audit. And therefore, it is not surprising that these studies cannot be the standard for good guidelines. Well, the German guidelines has implied preterm in the guideline for preterm labor, also a whole description how to use, that is this one, how to use these pessaries. And you can have this in English, so you can read it and you get some idea. And also the European guideline for preterm birth says there must be teaching, and that is what we do today. How to use these devices. It is somehow a shame that on the cover of the American Journal of Obstetrics and Gynecology, run by Roberto Romero, you see here a twin pregnancy. This was in 2016 when the cerclage pessary was described by two different teams with two different success rates, one by the female Elena Carreras and Maria Goria, and one study by Kypros Nikolaidis, and both had contradictory results. And I can tell you why, because these ladies knew and they had followed teaching courses with me, whereas Kypros Nikolaidis knows everything from heaven. And therefore, he just had no schooling, and he also admitted that he had no teaching. He never used pessaries, but he taught others. So this would not function in operative medicine, but it also doesn't function in medical products. And as you see here, the Seclage pessary on the title is inserted in the wrong way, because it is bottom up inserted. And that shouldn't be published, and surely not on the cover of the American Journal of Obstetrics and Gynecology. So the German guideline, meanwhile, recognizing that there are differences in these studies, says that the cervical pessary is a first choice in patients with a shortened cervix in multiple pregnancy, and it can be placed together with progesterone in singleton pregnancies. Well, I have done a lot of teaching courses all over the world. This was a course in Malaysia. And therefore, I think even when you are a sophisticated obstetrician, you shouldn't be too good to teach simple things. If you look back to the first courses of Nicolaides, how he insisted to do yearly audits in the stupid measurement of nasal bone length, or cervical length, or nuchal translucency, and to repeat and submit pictures, it is not to understand that such a complex syndrome like preterm birth should not have the same attention and the same teaching and audit procedures. And the reason for that is that when you are a student, you are smiling. When you become older, you become more and more busy with money and financial projects of your hospital and staff politics. And you become more and more unhappy, and you dream to be a student again, but please do it. Please do it every day and try to learn. And healthcare providers and physicians, we have found out, do not read the instructions for use, do not explain them for patients. And therefore we have introduced also a video in our on our homepage by Professor Alfirovic, who is different from the others. And I advise you to look at that. And it's very easy there to follow this YouTube, maybe easier than to my lecture now, but it is a very practical video. Well, in indicating pessaries, and I therefore now try to give you some practical hints how to use the cervical pessaries. We don't use strict cutoff values like in cervix of 2.5 millimeters you should start to indicate, because the background risk determines about the deterioration of the cervical shortening. And in risk patients after, for instance, ART, or who had already a history of preterm birth, the background risk determines, well, then you see very rapid shortening of the cervix. So it is much better to use centile values, because then you can see when you have two measurements on which percentile you have been and where you are now. And you see also the speed of the cervical shortening. And in addition, you have to be aware that cervical length is not like the biparietal diameter, a stable measurement, because physiologically, even during a measurement, you can have funneling going up, well, opening the internal os and closing again, and you see these changes. And also when you insert a pessary, you can see these changes. Here we have translated the study of Goya into icon errors, where we explain the patient. When you look at 100 women and you look, you imply a pessary, then without a pessary you have about 27%, with a cervix of below 25 millimeters at 24 weeks, who deliver preterm. When you imply a pessary, it's much less, and that they understand easier than any meta-analysis. So the the health literacy of the patient is very important to make her understand what is going on and to give her reassurance, because reassurance is important to reduce her stress, and because all women who have a sign of preterm birth are of course worried, and the stress again is harmful not only for the preterm birth symptoms, but also for the baby in terms of higher cortisol. Well, you also have papers which indicate that the Cerclage pessary is a treatment of urinary retention or of kind of prolapse. But in severe prolapse, it is contraindicated. So before you indicate a pessary, you must also know when you should not indicate a Cerclage pessary. This was a patient who had a Cerclage pessary, and the uterus, which was grade 4 prolapse, pregnant uterus, prolapse through the pessary, and luckily there was no necrosis, and I could cut it with a scissor and then applied the right one for prolapse, because she had no symptoms of preterm birth, she had symptoms of prolapse. There's also no use to imply a cervical pessary when you have had a tracheolectomy or several conizations, because when you have no cervix, you cannot rotate it. And you better then do an abdominal cerclage. You should also not use a pessary when the patient comes in already with regular contractions or signs of chorioamnionitis, microbiological invasion. This was, for instance, and you must sometimes decide whether you leave a pessary or not. This was a couple who had twins, lost twins in their first pregnancy after artificial reproductive techniques. And then, unfortunately, because it's always used in a private setting in Germany, she again came late in her second pregnancy with symptoms of preterm birth at 20 weeks. We placed a pessary, and the children were already very deep. There was already a funneling and a very short cervix, but we left the pessary in, and there was so much pressure that this baby was born with this sign of a ring. Well, the parents were not worried, that of course disappeared, but you can also see that the cervical pessary holded the pregnancy, and she at least went home with 2 healthy children. So I have already commented on a wrong placement. So it is very important to place the pessary with a small diameter up and the large right, because otherwise this effect of a rotation, this is wrong, cannot be fulfilled. And the secret is when the woman gets up, then the pessary turns. So it is then when you investigate, you feel this rim of the pessary, because it rotates the cervix towards the sacrum. So this is wrong and this is right. And then when you investigate the patient here, you just feel when she is this rim of the pessary, and then it is nicely placed. Well, another step is to use a checklist and an audit, because it's not only a matter of insertion, it is also a matter how you follow up. So when you place a pessary, you should always see the woman after 1 week and control whether the pessary is still in place, surrounding the cervix with the upper inner circumference. And I always let her stay up and lie down again to examine after this changes of the position. well, in case you perform studies, there should be an audit of the ultrasound pictures, and better you do 3 ones, because as I said, the cervix can change during an examination, and the problem then might arise how to control the cervix when the pessary is already placed, because the pessary absorbs ultrasound waves. So I perform the transducer. I place the transducer on top of the pessary by pushing the pessary towards the sacrum. And because then I have less manipulations instead of doing the control behind the cervix. I much more prefer to do it on top, although it is published differently by Goya. The transvaginal examination should be limited, because it's also a kind of manipulation, but it also has the function of a reassurement in study protocols, but also for the patient. And one important issue is really, I mean, there are so many stupid colleagues, I'm sorry to say that, but who mix, also in the study of Nicolaides in the New England Journal, nearly 50% of the patients got antibiotics only for discharge. And I want to make it clear, all pessaries, gynecological and obstetric ones, have as a side effect an increase of discharge, which is individually different, but discharge is not infection, and the spectrum of the discharge does not change the typical individual characteristics of the microbiome of the individual patient. So when she has discharge, antibiotics are not indicated, because the vagina is physiologically colonized by bacteria, and the bacteria do not change due to the pessary. It's just a reaction of the tissue towards a foreign body, which is not harmful. Of course, you have to differentiate whether it is not preterm rupture of membranes, but that is easy to differentiate by ultrasound and biochemical tests. And when she has untreatable, painful regular contractions, the patient, then you should really remove the pessary, because when you leave it during birth, of course, it can cause conization. If a patient comes in late and the device is stuck, you should not use violence, but just take a scissor, because it's anyhow a one-time device, and just cut the thing with a scissor you use also for episiotomy. The cyclage pessary is designed and registered for secondary prevention of preterm birth. It is CE certified, and it can also be very helpful in overdistension, in polyhydramnios multiple pregnancy. There, I think in triplet and twin pregnancy, it is really very useful, because it rotates the cervix, and it prevents from the stretching, and thereby also prevents the secretion of interleukins, which are also induced by this stretching. And the best pessary is not meant to close the cervix, but to reduce the tension by changing the uterocervical angle. And as I said, use centiles, and the surveillance should be preferably, and that is also in the instruction, not be done every time by a different person. It is better that reassurance and comparisons are done by the same follower. Well, the size is easy to indicate. There are different sizes, but I think most of them you don't need. So they have, all pessaries have an outer diameter, which is either 65 or 70. When a woman has a smaller and she has not yet vaginal delivery, I always use 65. And when she has a large vagina, I use 70. This is the lower. The height, it is for singletons, it's sufficient 21 millimeters and 25 for multiple pregnancies. These are a bit more stable in terms of the compression forces you need to fold them. And then you have the inner diameter. This is usually in routine indication 32. And when there is a wider cervix or U-shaped funneling, I use 35 in order not to manipulate the cervix or to compress it and cause prostaglandin secretion. And these are all not absolute indications, because usually it is enough to use 32, 21, 65, and for twins, 32, 25, 65, or when she has a wide cervix, 70. So you need maybe in your store about 4 sizes, and only in patients who come late, with U-shaped funneling, I use 35. Well, teaching is important, as I said, in all our guidelines. And we recommend to view the YouTube of Professor Alfirovic and to read the FAQs, so the frequent asked questions on our website, and to study some of these guidelines, how to use the pessary. And during insertion, the device remains folded, surrounding the cervix, but sometimes it can descend when the woman has obstipation or some kind of prolapse, and then she can taught herself to push it a bit up again. And how to remove. Before removal, the cervix should be pushed back carefully. It's also on the video. And if it's too much stuck, just cut it. If you plan a cesarean delivery, we have normally left the pessary and removed it in the operation theater. But in case of preterm premature rupture of membranes or any signs of infection or bleeding, it's better to remove the pessary, because the side effects of an infection are also for the child are worse than a preterm delivery. Well, as I said, we re-examine the patient after 1 week, and then we check the position of the cervix, if the pessary still surrounds the cervix. And as I said, it is better, because the consequences for the child are so severe, to have a really specialized preterm birth clinic. I always recognize that it is bagatellized, because the examination is in fact not so difficult. Everybody can do this after a short while. But it is more complex to know all other factors leading to preterm birth, because it is not only the cervical length which determines the severity. It's sometimes the whole setting, socio-economic setting, stress, obstetric history, and so forth. And of course, you can use other treatments in addition, because it's not it's a syndrome of many causes, not determined only by the cervical length, not only treated by pessary alone. And empathy is also an important issue during your controls. Well, as I said, don't confuse your patient when she reports on discharge. Say that it's very normal, and just exclude when you are not certain preterm rupture of membranes. So medical products, empathy, and humbleness. I called this slide. This was the first patient why I started. It was a mother of twins. She had lost 2 singletons before 20 weeks, and she now had a twin pregnancy. She had a cerclage, and the cerclage had funneling to the stitch, which was ruptured. And I, of course, was very anxious that she would lose again 2 children. And there I saw no other, I couldn't place a recerclage here because you stitch the membranes. And so I placed a pessary out of despair around this cervix, which had really no endocervical length at 17 weeks. And I experienced a kind of a miracle. I left the patient at home, and she delivered these twins at 36 weeks. Oh, this was nice. And I thought it was somehow special in this patient, and I repeated, because I had a lot of preterm births, I repeated the therapy in others and had always positive results. Of course, it might have been that my empathy and my passion with all my patients also played a role, and not only the pessary. So in my case-controlled studies, it worked as compared to other colleagues who did not use the pessary. So I recommended a randomized controlled trial performed by others. And I also asked my team in Brussels, Professor Jani and his wife, Professor Kani, who is a radiologist, to place it in twins with GTTS and polyhydramnios. And they, I don't know what it is. Oh, this is, we have a general alarm in Germany now, exercise, excuse me. And they found that before and after pessary, they did MRI. This is published in the White Journal. And they saw that funneling disappeared after placing the pessary. And they saw also that the angle, the uterocervical angle became closer, smaller. So this was quite an objective documentation how the pessary worked. And we also did biochemical, biophysical examinations in Sheffield in a special laboratory where we did pressure experiments, and we could observe how the pessary relieves the pressure to the lower uterine segment when it is placed in a right way, and it doesn't matter whether you placed 35 or 32, so whether it's loose or not, but when you place it upside down, the effect is even harmful, like on the cover of the American journal. So these were the results of the first study of Maria Goya, whom I taught myself, and she also followed her patients herself and had a small group of experts who followed the patients. And therefore, these results were so positive, she could significantly prolong pregnancy. This is the blue pessary group in comparison to expectant management. And she also could improve significantly the outcome. And this was published 10 years ago in the Lancet. In our department, one of my fellows also compared pessary versus pessary and vaginal progesterone. And neither in routine patients nor in patients with a history of risks, this is also published in the American journal, he could find differences apart from some days less on the neonatal intensive care unit, but this was a historic control. And you see here, there were no significant differences whether you used pessary or pessary plus progesterone. There were also the first study in twins in the Netherlands, where they placed pessary in all twins with a cervical length below the 25th centile, which was at 16 weeks 38 millimeters. So you can adapt the percentiles to the gestational ages. And in that study, it was very significant. Although I always said it is not for every twin, they did it in every twin, then there was no effect. But when you look at those who had a shorter cervix, the death rate was significantly reduced by the factor of 6. So 18 babies died in the no pessary group versus 3 in the pessary group. And there was also an improvement of the neonatal outcome of these twins with pessaries, although the teaching was still poor. Well, the best on most convincing study was in Vietnam, because they have, I think, one of the largest hospitals for obstetrics in the world. And they have 1,000 twin deliveries a year. And so they placed it also in all, they compared pessary versus vaginal progesterone 400 milligrams and compared the outcome. And it was much better in mainly when you look not at all. Even there was a significant effect in the reduction of preterm birth before 37 weeks and admission to NICU. But the effect was, of course, more pronounced in patients with a short cervix. And also the neonatal outcome, like RDS and sepsis, were reduced by the factor of 4. Comparison here, it was with pessary, and sepsis was only 6.7, with progesterone 24%, or the delivery before 34 weeks, it was 20 versus, so doubled, versus 44%. So the advantage of that study is that there was a limited group of obstetricians, and not like in the study of Nicolaides or of now the British team, distributed to people who had no idea and only placed a pessary once in their life. These group had some experience, and they followed the patients until the trial was finished throughout pregnancy, and that makes the difference. And when you look at this meta-analysis of Romero, who never placed a pessary, he compares really studies which cannot be compared. For instance, Hui, she said she did pessary blinded. How can you insert a pessary blinded? It's fake, it's rubbish, and patients should know that they have a pessary. It's also unethical. So according to the MDR, medical device regulation criteria, we used and compared the technical, biological, and clinical criteria, and some of them used different pessaries, whether they were equivalent to our instructions or not. And the green ones are the equivalent ones, and when you make a meta-analysis from these who are equivalent to the instructions for use, who did audit and teaching, and then you get positive results. So the advantage of the pessary, it's cost effective. This has been proven in several publications. It's cost effective. There's no hospitalization as long as you don't have a very short cervix, or you are at the, of course, we also hospitalize patients who are at the border of viability and still have a pessary. But normally when you place it early, you have no hospitalization, and the mothers may stay at home, which is also not only a cost factor, but also a social
Ben yazıyorum şimdi WhatsApp'ta. Herhalde tekrar bir düşüp bağlanabilir. Arıyor. Hi, Dr. Arabin. Yeah. You are now frozen. Your image is frozen. You are coming again. Okay, we are just waiting for you. Thank you. No problem. Waiting for you. Yarım saatlik konuşma demiştik. Biraz uzadı ama sanıyorum bitirmek üzere. Herhalde bir 5 dakika içinde toparlarsak, daha sonra da soruları alırsak zamana yetişiriz, toparlarız diye düşünüyorum. Bu arada chat box'ta herhangi bir soru göremiyorum ama belki canlı soranlar olabilir. İsterseniz bir 2-3 dakika bekleyelim Arabin'in gelmesine.
Esasında bizim daha sonra sunacağımız makalelerin içeriklerinden de şeyler sundu kendisi.
Evet, biz de daha kısa sunabiliriz ve daha sonra biraz tartışmaya vakit ayırabiliriz.
Yani sonraki makalelerin sadece şeylerini sunarsak, yani hangi amaçla yapılmış, materyal metodu kısaca nedir ve sonuçlarını.
Evet. Geliyor zaten, bağlandı şu anda hocam. Görüyorum kendisini. Herhalde share screen yapmaya çalışıyor şu anda. Hi, Dr. Arabin, you are connected. Can you hear me? Welcome back. We can see you.
Yes. Can I share? Can you give me allow me to share the screen?
Okay. Now you are allowed.
Okay. Oh, it all collapsed. I'm sorry, I must open it again. So we were here. I'm nearly finished. Can you see the screen?
Not yet. Could you share the screen? Were you able to share the screen?
Yes, just a moment.
Okay. Now you have started screen sharing. Okay, thank you. We can see it.
Okay.
You can continue.
Well, I'm sorry for that. As I said, also in COVID-19, this was quite an advantage because people could longer stay at home and avoid all the anxieties they have in hospital. So just to show you where we also sometimes are confronted with is problems of prolapse combined with a short cervix. Then in mild cases of prolapse, you can place a pessary, but when it's only prolapse or severe prolapse, I would not indicate it. And I'm now dealing, this is another topic, of course, but it is also a taboo how many people, women already in the 3rd trimester have symptoms of pelvic floor disease, and they are the same who later 1 year postpartum have the same symptoms. So we must always be aware of some kind of mixtures and with these other symptoms. So medical products in obstetrics, decade goals. Well, I think that in many studies you have the impression that researchers think they are only good researchers when they ignore empathy and good clinical practice. Because in the also in the Cochrane tools, this is no factor, good clinical practice. It's only statistics and mathematics. And of course, woman and even the cervical length is no statistic. It is changing, and a lot of other factors are determining about the deterioration of preterm birth symptoms and the final event. So there are new meta-analyses going on, separating the quality of these studies. Medical providers should get more training. There should be also a continuity of care, whether you use a pessary or not. I think for patients at risk for preterm birth, this is very important, mainly after artificial reproductive techniques. And the financial aspect should really be no aspect. And the post-market surveillance research should evaluate also for our devices the satisfaction. So and the effects. There's a good study now from Italy showing that in the hands of experienced doctors, women were extremely satisfied with the cervical pessary. But it also depends on the teaching and the empathy and the care. And we should improve health literacy of pregnant women in relation to many factors, also to symptoms, but frequently this is discovered too late. Well, the meta-analysis, which is now finalized and will be submitted now, more or less concluded that when only trials with high clinical quality and audit are considered, there is a significantly reduced rate of preterm birth and poor outcome, both in singleton and in twin pregnancy. And I think physiologically, of course, in multiples, this is an ideal tool because progesterone does not really work. And it is not surprising that the diagnosis and the therapy of a complex syndrome with many causes requires audit procedures to reach significant effect. And that the fact that the cervical pessary has such low risks in unexperienced hands, it has been widely used, been spread all over in hands who should not have started. And that didn't really harm, but it also didn't have the benefit it could have. And non-audit randomized controlled trial mixing studies of low and high values by predefined criteria, ignoring the legal implications of instructions for use, should not be the standard for future guidelines. Well, globally, I think it is relatively easy to teach also in middle income and low income countries, healthcare providers, how to place and to remove the pessary, but in patients where there's no supervision, it should not be used because you must, of course, remove the pessary when labor starts. And when that is not guaranteed, it is not indicated. well, we are now very much, well, I told you that I use the benefit of this company for other projects, and my favorite project is now to reduce stress of pregnant patients, which they had enormously during Corona times, and also now in countries like the Ukraine or all over, where we have a lot of refugees. And we have programs of music and creative workshops and singing, and the Berlin Philharmonics play for them every 2 weeks. So I finance the scientific evaluation, what it does, and we have from the first year already very positive results. So also the coordination with preterm birth syndromes and stress should be evaluated in these groups. We had in this creative intervention program, we had no preterm birth up to now. Because they get care, they get empathy, they have fun, and that is also very important. And therefore it's not only a device, you know, it is the whole setting you provide of reassurance, of care, and also, of course, you cannot prevent every preterm birth, also of awareness and knowledge. So I thank you very much. And this is the end of my talk. You can go to our website, or you can mail to me if you have special questions. And I'm open for questions now.
Okay, thank you, Professor, for this comprehensive review. First of all, I think the story of this Pesser resembles the story of the corticosteroids. As you know, the corticosteroids first randomized trial was performed around 30 years ago, and it took only 30 years for the whole world to accept it to use for the pulmonary maturation of the neonates. For having that wide acceptance, I mean. So for the Pesser, I think since it's a medical instrument, its availability is important, and as you stated out, the education is very much important. And if you are not very well educated about its use or about the appropriate size for the ladies, you can give harm instead of giving any benefit to the ladies. So I think people find it easier to use the progesterone because it's just a medication you give to the ladies, or they make the circlage operation because it's it's taught during the residencyship program for the obstetrics and gynecologists. And as a perinatologist in the area, I can see lots of circlages which are stitched inappropriately. I saw lots of stitches just at the level of the external ostium, and they don't work.
They don't work at all.
They don't work at all. And the circlages which are failing, most of the time performed with a wrong technique. And therefore, some women need transabdominal circlages, but maybe they don't need the transabdominal circlages. They need a better instrument like the Pesser or just a betterly performed circlage. So,
yeah, but what I showed, if I can interrupt, and there are also a study published by Kuvernitakis. I mean, nothing is perfect in medicine. You can put cerclage Pesser on top of this cerclage operation, and it still helps, because the advantage of the Pesser is that you can use it in funneling. When you restitch a cerclage with internal funneling, then you have a high risk of getting more infection and preterm rupture of membranes. So when you place a Pesser on a cerclage operation which does not hold any longer, it just rotates. So that I had several patients and it works well, just to give some idea. And maybe it's even a good combination to do both. I mean, in urogynecology, there are a lot of German very good surgeons. When they operate a prolapse, they set also after the operation a pessary to prevent too much pressure on the sutures.
Yeah, you're absolutely right. And on the other hand, I wonder about the evidence. Do you think the evidence is enough for the regular obstetricians to start to use the pessary? I mean, you have gone through all the evidence, and we are aware of so many guidelines that they just recommend to use it only in context of researches. So an obstetrician, not in Germany, like in Turkey, like in another country, believes in the evidence and starts this treatment despite the guidelines recommending against?
Well, the guidelines are frequently made by politicians who are not any longer in clinical care. I have always been in clinical care. So you are confronted, like you say, you get a patient, she has a cerclage, and the cerclage is, as in my case, is more or less not functional. And then you can say, oh, I have my guidelines, go home and deliver, or it's anyhow useless because progesterone does not work in this case. Well, I'm also a clinician, you know, and I'm responsible also for each single patient. So I have used them due to my obligation and my oath to the patient, and I was successful. I would do it because I don't trust a study like that one of Kypros Nikolaidis, though published in the New England Journal, where he distributed pessaries, and we got the parcels back because the clinicians from China or Australia did not know what to do with these devices, whether to hang it in the ear or how to place it. I mean, these studies are statistically perfect because they collect enormous amounts of numbers, but in fact, they did not use it like they should have been used. So it depends very much, and I would not say that cervical pessary or progesterone, you can do both, but at least I know, and it's proven, it is proven, the only studies by MRI, that you have an elongation of the cervix after placement. It is proven that it changes the angle, and those studies where I know the clinicians, they get good results. You understand? Yeah. It very much depends on the attitude of the doctors. When you, of course, perform a study, no matter whether you place a pessary and you remove it when she has some discharge, or give antibiotics, changing the microbiome, this is stupid. I think mainly in multiple pregnancy and in triplets, it does a lot of good, and I would use it. But I might be so-called biased, but less, really not by financial aspects, but by maybe emotional aspects, because I was also, like you said, brought up not to use pessaries until I was 45, and I had the desperate situations all over again in the Netherlands to run a preterm birth clinic and to saw desperate cases. So that was a difference. And then I was adult enough to not consider these guidelines. You understand?
Yeah.
So, and then I never had any harm by a pessary. I mean, it does not do harm unless you leave it. I mean, how stupid can an obstetrician be not to remove a pessary during labor? I mean, when you don't remove a cerclage, when the woman is in labor, you can have maternal death because she can bleed or get ruptured, vessels can rupture. So this is, of course, basic clinical knowledge or when I read in the Kypros-Nicolaides study that they removed a pessary under anesthesia, they have not read the instructions, you just cut it. Or when I read that 40% got antibiotics to the discharge, they did not read the instructions. They were not taught. Yeah. And he admitted that he did not teach them in a letter to the American journal. So it depends. But of course, you have also patients where the pessary does not work. When they have infection, of course, it does not treat infection. I would not place it. And I think it is also an art to know when you don't place a pessary, you know. The earlier, now there are studies by Professor Kyvenitakis that the pessary also changes the stiffness, which you can measure by new equipment. And the stiffness changes first before the cervical length changes, like in the Bishop's score, it's one criteria. So maybe we should, of course, for statistics, the success is a bit less when you start early, but clinically, you don't lose much, you know, and you can leave her longer at home. So, okay. I really think that everybody should try herself or himself to get some confidence with the device. And you cannot do harm in the beginning, but the benefit increases the longer you get to know how to act.
Mm-hmm, mm-hmm, mm-hmm. Yes, you're right. So the experience and the education are the most important steps for the...
experience mainly because, well, theory is nice, but it's much nicer to follow your own patients. And at least you cannot do much harm with this thing. That has been proven in all studies.
Yeah, you're right. Okay, thank you very much. And now I'm checking the chat box, and I'm also asking the audience if there are more questions, as we have found you, the expert. So maybe people have some questions to ask to you. So I'm just checking the box, and I'm asking the audience for any questions. I think this has been a very, comprehensive lecture. Thank you very much. And you have also given all the contact details. And I have also gone through the education video given by Alfrevich on the YouTube, and I found it really very, very helpful. So yes. For a starter, it would be a good start to have the education, because education is so easy nowadays on the YouTube. If you know the right system, if you know the right place, the right site to go, you can complete education and then start the application of this material in your high-risk patients. So thank you very much. In your very, very busy schedule, you have created some time for us, and we really appreciate this, Dr. Arabin.
And what I appreciate is your empathy, but I think because also in our music projects, what patients mostly appreciate is empathy, and that is not measurable by statistics. So we should not feel ashamed as women, as obstetricians, to be caring, It does not depend only on drugs and on devices. That is, I think, after 40 years in this field, I really come back to this point easily, and I thank you therefore for caring.
Yeah, I totally agree with you, and I really congratulate you for your great efforts, and I wish you all the best for your coming work. Okay, thank you very much. Okay, bye. See you. Bye bye. Şimdi arkadaşlar zamanımız kısaldığı için diğer konuşmaya geçeceğiz. Biz bir de bu çalışmaları biraz gözden geçirmek istedik. Sevgili Ebru Alper bu İtalyanların Pesser çalışmasını bize sunacak. Yaptıkları randomize kontrollü bir çalışmayla alakalı. Ben şimdi Birgit'e rica edeceğim. Hı hı, tamam, kapattı. Sevgili Ebru Alper, evet. Teşekkür ediyoruz.
Duyuyor musunuz? Duyuluyor mu ve görülüyor mu? Önce onu sorayım.
Duyuluyor ve görülüyor. Ekranında şey
Tamam,
yaparsan,
büyüteceğim.
yaparsan başlayabilirsin.
Tamam. Çok kısa süremizin kalmadığının farkındayım. Ben Napoli'den bir çalışma sunacağım ve Pesser'in spontan preterm doğumu önlemedeki rolü ama seçtikleri grup tekiz gebelikler, short cervix ve daha önceden erken doğumu olmayan hastalar. JAMA'da 2017 yılında yayınlanmış çalışmanın sorusu şu: kısa cervix, tekiz gebelik, daha önceden erken doğum öyküsü yok. Servikal Pesser kullanımı 34 haftadan önce spontan doğumu engelleyebilir mi? Sorumuz bu. Diğer şeylerimi geçiyorum. Başka mekanizması ile ilgili zaten Doktor Arabin ayrıntılı olarak bahsetti. Çalışmadan kısaca bahsedeyim. Tek merkezli paralel grup randomize kontrollü çalışma. Dediğim gibi herhangi bir daha önceden preterm doğum öyküsü olmayan tekiz gebelikleri içermekte. Ve 25 bilimin altında servikal uzunluğu olan hastaları çalışmaya almışlar. 18 hafta, 23 hafta 6 güne kadar olan sürede randomize etmişler. İki gruba ayırmışlar. Servikal Pesser ve Pesser olmayan grup şeklinde. Çoğu gebelikler alınmamış ya da randomizasyon sırasında membran rüptürü, koruyamniyolit, kanama, plasenta previa gibi sorunları olan hastalar ya da düzenli uterine kontraksiyonları olanlar çalışmaya alınmamış. Randomizasyon hakkında çok detaylı bir bilgi vermişler. Çok uzun anlatmayacağım. Kısaca bu tamamen ayrı bir bağımsız istatistikçi tarafından yapılmış ve hiçbir şekilde çalışma ekibinin buna bir dahli olmamış. Ve onlar bu işe tamamen blinded olmuşlar. Ve daha doğrusu şöyle, çalışma ekibi tabii doğal olarak hangi hastada Pesser var hangisi biliyor ama istatistikçiler ve analizi yapanlar bundan habersiz olmuşlar. Randomizasyon sırasında da yine bir spekülüm muayenesi, kültür alınmış, herhangi bir enfeksiyon var mı buna bakılmış, enfeksiyon olanlara antibiyoterapi verilmiş. Ve burada bir dikkati çeken nokta ki biraz evvel Doktor Arabin çok detaylı bahsetti. Tüm servikal Pesser'i yerleştiren doktorların hepsinin bununla ilgili özel bir eğitimi olduğunu yazmışlar ve sertifikasyonları olduğunu yazmışlar. Ve daha sonra da bu servikal Pesser'ler 37. haftaya kadar bırakılmış ve o zaman da çıkartılmış. Erken çıkartılma nedenleri aktif vajinal kanama olması, düzenli kontraksiyon olması, dilatasyon ilerlemiş olması ya da hastanın çok rahatsızlık duyması gibi nedenlerle çıkartılmış. Kontrol gruba da yine aynı şekilde aynı obstetrik bakımı vermişler ve servikal uzunluğu 20 milim ya da daha az olduğu durumlarda da vajinal progesteron ovüller 36 hafta 6 güne kadar her iki grup içinde kullanılmış. Herhangi bir yatak istirahati ya da cinsel ilişki kısıtlaması, aktivite kısıtlaması ile ilgili bir önerileri olmamış. Outpatient olarak takip etmişler. Burada biraz evvel Dr. Arabin'in tavsiyesinden ya da önerisinden farklı olarak her ayki kontrolda her hastaya aylık dijital bir muayene yapılmış. Yani pelvik muayene yapılmış hastalara. Gerçekten Pesser doğru duruyor mu, durmuyor mu diye. Ama bunu çalışmanın sonunda tartışma kısmında araştırmacılar özellikle üzerinde durmuşlar. Biz bunu böyle yaptık ama bunu bir şekilde önermiyoruz. Hani bu bizim önerimiz değildir. Bu tartışılabilir ve farklı şekilde uygulanabilir demişler. Her follow-up vizitte de hastaya yan etkilerle ilgili özellikle progesteronun kullanımı, uygulaması ile ilgili sorunları var mı? Pelvik bir rahatsızlık, ağrı var mı? Vajinal akıntı var mı? Bunlarla ilgili sorular sormuşlar. Tabii ki 26 haftadan sonra da eğer preterm eylem başlamışsa buna uygun tedavi yapmışlar. Primer sonuç ölçütü 34 haftadan önce doğum olması. Sekonder ölçütlerse ayrı ayrı 37, 32, 28 haftadan önce doğum olması, doğuma kadar geçen süre, 34 haftadan önce preterm membran rüptürü, doğum şekli, maternal side efektler, neonatal sonuçlar, doğum kilosu, NICU'ya giriş ve kompozit prenatal outcome'lara bakılmış. Şimdi 503 hasta screen ediliyor, 203 tanesi exclude ediliyor, 90 tanesi zaten katılmayı istemiyor, 84 tanesi 25 milimin üstünde olduğu için ikinci transvajinal ultrason kontrolünde zaten çalışmaya dahil edilmemiş. 300 tane randomize ediliyor, 150-150 eşit şekilde ve her bir grupta 133 tane Pesser grubunda, diğer grupta 125 tane hastada 20 milimin altında olduğu için servikal uzunlukları progesteron oluyorlar. Demografik verilerinde bir farklılık yok. 20 milimetrenin altında olanlar her grupta da oldukça yüksek. Pesser grupta %88.7, diğer grupta %83.3. Ortalama servikal uzunluk 11,5-12,5 arasında değişmekte. Bu tabloda işte her şeyi görmekteyiz. 34 haftadan önce spontan doğum oranları arasında Pesser grubunda ve Pesser olmayan grupta istatistiksel anlamlı fark var iki grupta. 37 haftanın altında zira yine aynı şekilde. 32 ve 28. haftalarda bu fark izlenmiyor. Ama zaten şunu demişler, biz power analizimizi 34 haftaya göre yapmıştık. 32 ve 28 hafta için bunu düşünmemiştik. O yüzden çok üstünde durmamışlar. 34 haftadan önce istatistik anlamlı bir faydası görülmekte Pesser uygulamasının. Tabii ki bununla ilişkili olarak da doğumdaki gestasyonel haftanın ya da randomizasyondan doğuma kadar geçen süre Pesser grubunda çok daha yüksek, çok daha uzun. Vajinal akıntı biraz evvel de Doktor Arabi'nin belirttiği gibi Pesser grubunda çok yüksek. Hastaların %87'si neredeyse vajinal akıntı yapılmasıyla başlamış ama onun dışında bir poliamniyot ve pelvik ağrı rahatsızlık hissi açısından hiçbir farklılık yok. Elbette ki doğum ağırlıkları da Pesser grubunda daha fazla, daha geç doğum olduğu için NICU'ya giriş daha az ve kompozit perinatal outcome ki burada kastedilen işte RDS'ler, retinopatiler, bronkopulmoner displazi ya da NEC gibi patolojiler Pesser grubunda daha az. Sonuç olarak bütün bunlarda Pesser anlamlı olarak 37 haftadan önce doğumu engelliyor. Daha uzun bir gestasyonel doğumda daha ileri bir gestasyonel hafta olmasını sağlıyor vesaire vesaire ve gebe kalma süreçlerine baktığımızda tüm doğumlar ya da spontan doğumlar sadece ayrıldığında gebe kalma sürecine bakıldığında oldukça iyi bir performans gösterdiğini görmekteyiz. Pesser grubunun 40. haftaya kadar daha da ileri haftalara kadar gebeliği sürdürmesine yardımcı olduğunu görmekteyiz. Ve Pesser grubunda hastaların yaklaşık %65'inin 38. haftayı gördüğünü de söylemek mümkün. Çok kısa olarak da belki birkaç şey söylenebilir. Bu Nikolaides'in çalışması ki biraz evvel çok büyük eleştiri aldı Doktor Arabi'nden. Onunla ilgili bu grubunda eleştirileri var. Çünkü hiçbir şekilde bir eğitim verilmediğinden ve daha önce 3 RCT'nin incelendiği bir meta analiz kendileri yapmışlar zaten yine Saccone grubundan geliyor ve burada başarısız çıkmış Pesser. Fakat burada asıl sonucu belirleyenin çok büyük bir vaka sayısı olduğu için Nikolaides'in çalışması olduğu ve onun da ciddi eksiklikleri ve eleştirel noktaları olduğu öne sürülmüş. Bu yüzden de sonuçları domine ettiği ve buna bağlı olarak da RCT'nin başarısız çıktığı söylenmiş. Bunlar da Saccone bu çalışmada da yine biraz önce yine 2012 yılında Goya'nın çalışmasından söz etti Lancet'teki Doktor Arabi ve Lancet'teki bu çalışmaya göre Lancet'teki bu çalışma zaten Arabi Pesser'i destekler nitelikte. Nikolaides'in çalışmasından farkı Nikolaides'in aslında daha önce erken doğum yapmış olan hastalar da bu grupta yer aldığı için ve Goya'nın çalışmasından çok daha fazla bir oranda oldukları için farkın buradan çıktığı bu nedenle başarısız göründüğü gibi bir yorum yapmış Goya'da ve evet bitirdim. Giderek artan bir ilgi var Pesser'e ve oldukça yararlı, kolay kullanımlı, anestezi gerektirmiyor. Outpatient clinical ortamlarda uygulanabilir ve kolaylıkla çıkartılabilir diyoruz ve bitiriyoruz.
Çok teşekkür ederiz. Çok hızlı ve çok net bir şekilde toparladığınız için. Şimdi Erkan'a geçelim ki hızlıca 15 dakikamız kaldı. 15 dakika içinde hızlıca bitirelim. Zaten çoğunu gerçekten Birgit Arabin anlattı. Evet Erkan, seni dinliyoruz.
Merhaba hocam. Ekranımı
Merhaba.
görüyor musunuz?
Seni de görüyoruz. Sen hoş geldin.
Şimdi sunum gözüküyor herhalde.
Evet.
Ben ilk önce Doktor Arabin'in sunumu için çok teşekkür ederim. Aslında benim değineceğim farklı noktaları çok güzel anlattı. Kendi sunuma başlamadan önce ben şeyi söylemek istiyorum. Biz kendi kliniğimizde de kullanırdık. Ben bundan ne zaman bir sene önce falan böyle bir rastgele onun web sitesine denk geldim ve kullanımının nasıl yapıldığı ile ilgili o Arabin diye sitesinde bakınca biraz şey oldum böyle o falan diye böyle bu böyle mi takılıyordu diye. Çünkü işin doğrusu ben en azından bir iki tane şey hatırlıyorum kendi kliniğimizde. Hani o Kipros'un ters takmış diyor ya.
Evet.
Ters taktığımız şeyler biliyorum ben yani. O yüzden çok güzel oldu. Hani bir cihazın ortada olması ya da araştırmanın yapılması, araştırmanın yapıldığı anlamına gelmeyebiliyor. Bu da Kipros beyefendinin bir meta-analizi. 2 sene önce falan çıkarmıştı galiba. Randomize kontrol çalışmaları derlediği 12 tane çalışma var içinde. Şurada dahil edilen araştırmaları renk koduyla şey yaptım. Singleton 25 milimetrenin altında olanlar yeşil. Singleton 25 milimetrenin altında daha önce preterm doğum hikayesi olmayanlar mavi. İkizler pembe, ikizler karışık ikizler yani hani bu high order vesaire olanlar sadece ikiz olduğu için yapan servis kısalığı değil de ikiz olduğu için olanlar da hafif turuncu olanlar. Göründüğü gibi hani öyle çok da bir çalışma yok aslında. Hani şey gruplarında bakacak olursak küçük risk grupları halinde bakacak olursak her birinden 3'er 4'er tane var. Çoğu çalışmada Pesser olmamayla kıyaslamışlar. Bazı Pesser çalışmalarda Pesser'i vajinal progesteronla kıyaslamışlar. Bir de biyotek kap diye Arabin Pesser'i olmayan bir Pesser var. Onda sadece 2 çalışma kullanmış. Bu çalışmaların kalite değerlendirmesinin bias değerlendirme grafiği. Ben bunu görünce direkt şey demiştim. Hani açık hepsine tek tek bakma imkanım olmadı ama bir iki tanesine baktığımda bana birazcık fazla cömert gelmişti. Genelde bir kalite değerlendirmesinde bu kadar yeşil, low risk of bias, günlük gülistanlık işler olmaz diye. Ki Doktor Arabin de anlattığı üzere aslında burada tam da bahsettikleri gibi çiçek böcek bir tablo yok. En basitinden hani çoğu çalışmada körleme yok. Outcome assessor'lar sonuçları görüyor. Çıkarabiliyorlar, antibiyotik başlayabiliyorlar, ne bileyim tokolitik başlayabiliyorlar. Dolayısıyla körlemenin tam mümkün olmadığı bir tedavi türünde dolayısıyla bu kadar çiçek böcek bir tablo olmaması lazım. Bakıldığı zaman da aslında 2 tane çalışma hariç hiçbir çalışmada bir etkisi gösterememiş. Biri Goya'nın çalışması, biri Saccone'nin çalışması. Bu Doktor Araben'in söylediği yani çok ciddi bir iddia yani. Hani siz bu kadar çalışma yapmışsınız ama daha doğru düzgün şeyi bile kullanmamışsınız diyor yani. Hani yerleştirmemişsiniz diyor. Öyle olunca tabii ki doğal olarak sonuç çıkmaz. Öyle olunca da bu metanalizin de çok bir anlamı kalmamış oluyor. Yani eğer tedaviyi düzgün uygulamadılarsa zaten hani burada sonuçlar arasında olmamaları lazım. Bu ciddi bir itham ama hani görüldüğü kadarıyla da doğru yani. Hani doğru şeyi kullanmamışlar. Baktıklarımızda vajinal discharge ve pelvik ağrı hissi dışında Pesser uygulaması olmayanların tekil gebeliklerde 25 milimetrenin altında serviksi olan tekil gebeliklerde bir farkı olmadığını görüyoruz. Vajinal akıntı Pesser kullananlarda daha fazla %66'sında görülmüş ve Pesser kullanmayanlarda %28. Ağrı pelvic discomfort şeklinde tariflemişler. %9 Pesser kullananlarda, Pesser kullanmayanlarda %2.8. Burada bir tane daha ilginç sonuç var. Tokolitik kullanımı Pesser kullanmayanlarda daha fazla. Bu randomizasyon olup da körleme olmayan bir çalışma için çok ilginç bir şey. Hani tokolitik ajanlar bir grupta çok daha fazla kullanılmış. Quality of evidence'da moderate, fena değil. Dolayısıyla bu da ilginç bir durum. Hani acaba şey durumda bu tarz bir bias olduğu zaman bu Pesser lehine olması daha yüksek ihtimal bir şey. Çünkü eğer bir grup daha agresif medike edildiyse, yapıldıysa, doğum haftası uzatıldıysa bir şekilde Pesser'in etkisini zayıflatmış olabilir. Ama baktığımızda da aslında şurada bir spontan preterm doğumda kümülatifte bir %10 azalma görüyoruz. İstatistiksel anlamı olmasa da. Genel olarak birkaç çalışmada da aslında eğer Pesser'in doğru konulmadığını varsayarsak ilginç bir fark yani. Burada genel olarak bakıldığında unselected multiple gestation'larda bir fark var mı diye bakılıyor ikiz gebeliklerde. Yine tek fark vajinal discharge'da görülmüş ve sezaryen doğumda görülmüş. Pesser kullananlarda sezaryen doğum daha fazla. Pesser kullananlarda vajinal akıntı daha fazla. Onun dışında bakılan hiçbir outcome'da farklılık gözlenmemiş. Bu da neonatal outcome'larda. Neonatal outcome'larda çok ilginç bir şey var. Retinopathy of prematurity. ROP'ta Pesser grubunda bir artış var. 4 kat kadar. Confidence interval'ı çok geniş. Genel olarak da nadir bir outcome. Hani büyük ihtimalle tesadüftür ama yine de istatistiksel anlamlı olarak gözüken bulgular arasında bunun görülmesi ilginç. Hani preterm doğumda herhangi bir artış yok. Ona bağlı olamaz. Hatta burada neredeyse bronkopulmoner displazide bir azalma bile çıkmış Pesser kullanan grupta. Çünkü aslında baktığımızda Pesser kullanan grupta bu ikizlerde yok. Bu ilginç şeylerde. Singleton'larda vardı. %10 daha az bir şey. İstatistiksel anlamlı olmasa da. Burada öyle bir şey yok ama bronkopulmoner displazi hani preterm doğumla alakalı olabileceğimiz bir outcome yine Pesser grubunda daha azmış. O yüzden iki tane birbiriyle ters sonuç var. ROP daha fazlayken bronkopulmoner displazi daha az. İkisi de büyük ihtimalle tesadüftür, nadir outcome'lar olduğu için. Key finding'ler yani bir azalma yok diyorlar. Outcome'larda bir farklılık yok diyorlar. İncelenen gruplar risk altındaki singleton'lar 25 mm ile tanımlanmış olanlar yani. Unselected twin gestations ikiz gebeliklerin 38 mm ve 25 mm altında olanlar ama bunlarda da birer ikişer çalışma var yani aslında çok iddialı bir şey olmuş. Sanki orada evidence çok kuvvetli de bir bulgu varmış gibi. Genel olarak bir fark yoktur diyor. Ama burada bence en önemli olan dediğim gibi Doktor Arabin'in sunumunda söylediği noktalar çok ciddi bir itham. Zaten doğru kullanmamışlar ki. Eğer öyleyse zaten meta-analizin de sonucunun böyle çıkması şaşırtıcı değil. Siz hocam mute'siniz. Duymuyoruz sizi.
Tamam. Çok sağ ol, pardon vakit kaybı için. Çok hızlıca toparladın. Üçüncü çalışmayı ben sunacağım ama ben onun hemen sonucunu söylerim. 2 tane soru var. Sorular daha kıymetli oluyor böyle ortamlarda. Ramazan abi chatbox'a şöyle bir yorumda bulunmuş. Sonra da sevgili
Pesser'e ters söyledim ya da yanlış anlaşıldı. Pesser grubunda daha fazla değil tokolitik kullanım. Pesser'e olmayan grupta tokolitik kullanımı daha fazla.
Pesser'e olmayan grupta daha fazla tokolitik kullanılması.
Evet. Aynen.
Ama o durum daha kötü olduğunu da gösterebilir gibi bir yorum oluyor. Ramazan abi bir şey söyleyecekseniz söz alın, konuşalım. Evet, sevgili Ebru, görüntünü...
Merhaba, ben görüntümü de açayım. Bu protokolleri yazarken ben İngiltere'deydim ve protokolleri bizzat hocayla biz yazdık. Hem ikiz hem tekiz için. İkizde de 120 tane hastayı kendim bizzat randomize ettim. Ve Arabin'le birlikte yani biz birlikte oturup bunu organize ettik. Yani o geldi bize İngiltere'ye. Pesser'i nasıl kullanılır anlattı. Söylendiği gibi ters takmadık biz Pesser'leri. Arabin'in gösterdiği şekilde taktık hepsini. Hepimiz de eğitim aldık. Sonra yani ben kendim randomize ettim 120 tanesini ikiz gebeliklerde. Tekizlerde ben ayrılmadan 2 ay önce başlamıştık. Gene birçok insana da eğitim verdik. Öyle sanıldığı gibi her research fellow zaten bizde randomize edemez. Belirli insanlar randomize edebilir. Randomize edildikten sonra da o hastalar tek 2 ya da 3 research fellow tarafından eğitimi almış ve bu konuda bu çalışmayı yürüten insanlar tarafından olur. Yani biz yanlış takmadık o Pesser'leri. En azından kendi randomize ettiğim hastalar için söyleyebilirim. 120 de az değil sanırım. İkiz gebelikte 120 ve protokolü de hocayla birlikte oluşturmuştuk. Hatta ben dönmeseydim benim tezim falan olacaktı. Yani bu iş böyle, biz yanlış takmadık. Onu söylemeye çalışıyorum Pesser'leri.
Zaten Erkan da belirtti, yani çok büyük bir itham şeyinde bu noktasında. Zaten Arabi'nin de değindiği bu çalışmalar değildi sanırım. Yani daha ulusal bazlı yapılan çalışmalara değindi. Hani eğitim olmayan yerlerde çok doğru uygulamalar olmayabilir gibi. Ama tabii olayın merkezinde olan biri olarak doğru takıldığı bilgisini senden almak da bence çok iyi oldu. Teşekkür ederiz. Erkan, sen share screen'den çıktı. Son 5 dakikada ben bendeki sunumu sizle paylaşayım. Ondan sonra da şeyi bitirelim, toplantıyı bitirelim. Share yapamadım galiba ben. Evet. Görünüyor mu? Bir söyleyebilirseniz. Tamam. Burada da servikal Pesser'i 34 haftanın altında ki doğumu engelleyip engellemediğini ölçmek için, ama bir epizod erken doğum tehlikesi geçiren kadınlarda çalışmışlar. Prospektif bir çalışma, İspanya'dan 2008-2014 yılları arasında tek bir erken doğum tehdidi sonrasında servikal uzunluğu 24-30 hafta arasında 25 milimin altında olan, 30-34 hafta arasında da 15 milimin altında olan kadınlara Pesser uygulamışlar. Ve bu kadınlara bir gruba Pesser uygulayıp diğer gruba normal geleneksel tedavilerle hastaları göndermişler. Takılan Pesserler tek çeşit Pesser. 65'e 25'e 32 milimlik Arabin Pesser uygulanmış. Primary outcome measure olarak da spontan preterm doğum 34 haftanın altında oranlara bakmışlar. Toplam 357 hasta randomizasyona gitmiş. 179'una Pesser konulmuş, 178'i rutin olarak yönetilmiş. Gruplar arasında herhangi bir farklılık yok. Primer sonlanım noktası olan 34 hafta altındaki spontan preterm doğum oranları Pesser grubunda ve ekspektan tedavi yapılan grupta aynı bulunmuş. Ancak bu kaplanma yer analizde görüyorsunuz oranlar aynı. Ama 37 hafta için bu oranları incelediklerinde özellikle 37 haftanın altındaki doğum oranlarının Pesser grubunda daha düşük olduğunu göstermişler. Ve 37 haftayı tamamlayan gebelerin oranının daha fazla olduğunu göstermişler. Bunun için de hesapladıkları hazard ratio 0.57 olarak karşımıza çıkıyor. Yine bu çalışmanın önemli bir ölçütü, Pesser takılan kadınlarda zaman içinde servikal uzunluğun arttığını göstermişler Pesser takılmayanlara göre. Ve preterm erken membran rüptürü Pesser takılanlarda istatistiksel anlamlı düzeyde daha az olmuş ve tekrarlayan erken doğum tehlikesi de yine Pesser takılanlarda daha düşük oranda görülmüş. Bunu da servikal pozisyonun değişmesine bağlamışlar. Ve yine yan etkiler açısından baktığınızda da yine vajinal akıntı Pesser'li hastaların tamamında olurken Pesser'in çıkarılmasını gerektirecek ya da bir korioamniyonit tablosu Pesser'li grupta gelişmemiş. Ancak sonuç olarak gruplar arasındaki perinatal outcome'lar arasında herhangi bir farklılık olmadığını göstermişler. Bu 37 haftanın altındaki doğum oranlarını değiştiriyor, EMR oranlarını değiştiriyor. Ancak buna rağmen perinatal outcome'da da yeterli sayıya ulaşamadığımız için bu sonuçları net olarak görememiş olabiliriz diye çalışmayı sonlandırmışlar. Son olarak sizlere 15 Ocak'taki yapacağımız fetal kalp kursu, bir günlük bir kurs. Bu kursun duyuruları da yakında sizlere gelecektir. Bu kursa davet ederek bu haftanın Perşembe toplantısını kapatıyorum. Herkese katılımları için çok teşekkürler.